Hi, folks. Professor Gulliford here. We are on Chapter 16, Electrophysiology of the Heart. I am fascinated with EKGs and cardiac arrhythmias and really enjoyed it over the years. I decided to go take a specialty certification exam in cardiology. The credential is RCVT, Registered Cardiovascular Technologist. And if you guys get interested in EKGs and would like to do that, you are already qualified to do it once you finish your respiratory therapy training. I can't say that it did a huge amount for my career, but it did demonstrate to the medical staff and to everybody else that I had special knowledge in reading EKGs. And, that's been a positive thing over the years. My departments have always been cardiopulmonary, meaning EKG, Holter, cardiac stress testing, and then all the respiratory therapy stuff. Usually, I've also had EEG within the department. All of that done by respiratory therapists who get a little extra training in different things. So RTs are certainly the most adaptable of all healthcare professions. And this is one example of that. So let's take a look at the heart. Conduction system, the action potential, the normal axis of the heart, and things that can cause axis deviations, normal sinus rhythm, the cardiac leads, the EKG recording, supraventricular versus ventricular arrhythmias. That's an important difference. You'll see what we mean here pretty quick. And then identify common cardiac arrhythmias. There are probably about a dozen arrhythmias that you really need to know as you go take your board exams. The rhythmic contraction of the atrial ventricles is in relation to electrical impulses, and your heart has the ability to generate these impulses itself. It starts in the SA node, as you're going to learn, and the contraction is carried because of the movement of electrolytes, potassium, sodium, and calcium in particular, across cell membranes. If your potassium is out of whack, very low or very high, it can really mess up your cardiac rhythm, as you're going to learn here. There's a thing called a resting membrane potential. That's the electrical, what would you say, electrical level of the cells. And there are impulses called action potentials that actually cause the heart to beat because they cause the muscles to contract. That's really what this is about, is getting the heart muscles to contract and to produce a pulse, a blood flow. Yeah. And this is a look at how that all happens. I want to be perfectly honest with you and say there's nothing about this on your board exams. So you do need to learn this for the course. You particularly need to know that sodium and potassium are crucial in that. And the generation of an action potential is what causes the muscles to contract and the blood to get pumped. So, but that's about it. By the time you make it to board exams, we're talking mostly about cardiac rhythms and what to do about those rhythms. Action potential has 5 phases. Honestly, you don't need to know a lot about that, but it has to do with sodium and potassium exchange. For every 50 to 75 ions of potassium, they've actually got it pinned down. 1 ion of sodium will enter the cell, but that is so important, and it's that exchange of sodium and potassium that causes the impulse to be conducted through the heart. So sodium and potassium become really, really important to all of us. Stage 0 is depolarization. The SA node initiates a signal, and the potential climbs from -90 to +30. That's the firing of the SA node. Potassium channels open. Potassium ions rush out of the cell. Calcium ions start to flow into the cell. That's stage 2. Rapid repolarization as the inflow of calcium stops and the rapid outflow is resumed. And then polarization, which is the resting phase. So that's really all you need to know about that. That's the physiology that's behind the heart, but that doesn't really affect what we do clinically every day. So you're going to need to really learn the next part, which is the EKG. Yeah. By the way, why is it called EKG? Because it's German. The whole thing was invented in Germany by Dr. Einthoven. And he, of course, used K because in Germany that's cardio K with a K, just like kindergarten. So when you hear EKG, it's the same thing as ECG. Yeah. You need to know that every little square on the EKG paper is 0.04 seconds, and there are five of those in every big square, so every big square is zero point 0.2 seconds. That becomes important as we measure things like the PR interval. And we're going to start on that here in just a few slides. I looked ahead, and this is a great little PowerPoint about the EKG. We also use a lot of 6-second strips in cardiology. That's handy because a 6-second strip times 10 gives you a minute. So whatever the patient did in those 6 seconds, multiply by 10, and you're in good shape. There's the paper itself, 0.02 for every big square. 6 seconds is the whole strip, and then you do have millivolts on the side. I got to be honest with you, we don't often measure millivolts. We're more interested in the rhythm by far than we are anything else. Yeah. So standard bipolar leads, and there's Dr. Einthoven. Man, you know what? I'd love to show you a picture of the first EKG machine. I'm going to make myself a note to do that. I don't want to go there right now because we're going to lose this PowerPoint with all the other stuff that's open. But I'd love you to see that first EKG machine. It's fascinating. It was buckets of salt water, 2 buckets for the legs, 1 bucket for the arm, and then a ground wire. The first patient to get in that crazy first EKG machine had a lot of guts because I don't know how safe that really was, but nonetheless, it worked, and we moved on from there. That's what's called the triangle, the Einthoven's triangle. The right arm is a negative electrode. The left leg is a positive electrode, and the left arm can be either, depending upon which lead we're measuring. So lead 1 goes from right arm to left arm. Lead 2 goes from right arm to left leg, and lead 3 goes from left leg to left arm. So everybody asks the same thing. What about right leg? Right leg is your ground, and that is so important that the machine be properly grounded, both for patient safety and also so you don't have a lot of electrical interference. So there you go. That is the triangle that everything starts with. Shooting between those standard limb leads, which are 1, 2, and 3, we have something called augmented leads. And those augmented leads are AVR, AVL, and AVF. I don't know why they didn't list them here. Maybe they're going to do it on the next slide. AVR, AVL, AVF. And those are augmented leads that pick up areas of the heart that the limb leads do not. And then you have 6 chest leads labeled V1 through V6. There you go. So that's the configuration, and that shows you a good picture of the chest leads, also known as the precordial leads, on the patient's chest, V1 through V6. Getting those in the right spot is really important to make sure we measure the heart signal. So that'll be gone over in a lab. You guys will practice that. You'll do hundreds of EKGs during your training. You know, it's something every respiratory therapist does on a day-to-day basis. And it's not hard. Let's be honest. It is not hard. Right arm is white. Right leg is green. So for many years, what we have said there is it's clouds over grass. White over green, clouds over grass. On the left side, we've got the left arm, which is black, and the left leg, which is red. We say smoke over fire. Smoke over fire. So you got clouds over grass, smoke over fire. The leads are also labeled RA, RL, LA, LL. So it's just not difficult. But we're going to attach those to the limbs. We're going to put these leads over the heart, and away we go. The complex that's produced when we measure the heart's electrical activity, atrial depolarization, is the P wave. These are board questions right here, folks. These make it all the way to the boards at the end of your training. Atrial depolarization is a P wave. Ventricular depolarization is the QRS, and the T wave is the ventricular repolarization, or also could be called ventricular relaxation. Sometimes there's a U wave, sometimes there's not a U wave, but it doesn't have any real clinical significance to us. So PQRST, PQRST, you're going to see that a lot over the years. Now here's the thing, the PR interval, this is important, is normally less than zero point 0.2 seconds. The PR interval is normally less than zero point 0.2 seconds. If it is longer than zero point 0.2 seconds, that's considered a first degree heart block. First degree heart block. I imagine you've heard about heart blocks probably by now. If the PR interval is greater than zero point 0.20 seconds, you know what? They missed a decimal point over here on the slide. It should be zero point 0.2 seconds, not 20 seconds. If it's greater than 0.2 seconds, that is first degree heart block. And there you go. The Q wave is the ventricular depolarization, and really the QRS, all taken together, QRS really represents the in full contraction of the ventricles. It spreads through the septum, it spreads through the main walls of the ventricle, and then spreads through the Purkinje fibers, which are the tiny little fibers that go out to the ventricular muscle. Normally, it takes about zero point 0.1 seconds to do that. If it's more than 0.12, we say that is a delay. If the QRS is greater than 0.12, which would be 3 small squares, then that is going to be considered a delay in the ventricle. Somewhere in the ventricle, there's a delay. The height of the QRS is interesting. We don't often measure those, honestly. But here's a little hint. If the QRSs in the V leads, those leads that are right over the heart, if they're touching each other, then those beats are too tall, and it means you have an enlarged heart. That is hypertrophy of the heart. I'll show you a picture of that here. But that is an interesting observation to make. It actually amounts to more than 35 millimeters of QRS, shows you ventricular hypertrophy. Let's see, normal heart complex PQRST. It ought to be PQRST if it's going to be um, a sinus rhythm of any kind. Sinus rhythm means it comes from the SA node, and that is going to be the normal pattern of the heart. If it's anything other than that, we call it an arrhythmia. Now, that literally means without rhythm. So I'm not sure that that's true. That's a better word would have been dysrhythmia. Dysrhythmia, which means a rhythm that's not normal or is not good for the patient. But whether you call it arrhythmia or dysrhythmia, it's any abnormal heart rhythm. And let's see here. Another factor, we measure the QT interval. It's an interesting one. And that can tell us important things about the heart's contraction. The QT is longer when the heart rate is slower. When measuring a QT interval, the normal is up to 0.44 seconds. If it's longer than that, that tells us something is going wrong with the repolarization of the heart. And exactly what that is, will have to be determined in other ways. But we do look at the QT interval. Probably the most important interval is the PR interval. The QT interval would be next. Yeah. And finally, a picture. This is the PQRST that we're looking at. The start of the P to the start of the QRS is the QR interval, and it should normally be less than 5 small squares. This one is. Let's measure it. The atrial contraction is 1, 2, 3, 4, 5. Yeah, just about 5 small squares, so it is okay. The ventricular contraction should be less than 3 small squares, and it is, so we're okay on that also. This is what a normal EKG looks like. PQRST with normal intervals. The differing appearances of P, QRS, and T will tell us interesting things that have to do with axis and also with previous heart attacks, which is fascinating. One of the things that I've always been interested in is I'll see an old heart attack on an EKG. I'm taking the EKG of the patient and say, "Sir, I see that you've had a heart attack at some point. Um, when did that happen?" And the patient will say, "I've never had a heart attack." So particularly, let's be honest, for our male patients who tend to just kind of ignore things and pretend it's going to go away, a significant number of our male patients have a heart attack and they just think it's the flu or something like that. And they lay on the couch for a few days and recover, but they sure as heck have had a heart attack. We see it on the EKG. It's real and you will experience that in your own career. I'll show you how to recognize that. So, evaluating the P, Q, R, S, and T, has been so important in healthcare. Today, we know that we need not just the EKG, but we need cardiac enzymes. Cardiac enzymes. And the big one I want to mention, so you'll pass it on boards, is troponin. Troponin is an enzyme that goes up very quickly if the patient has had a heart attack, and you need to be aware of that. A rising troponin level means the patient is probably having a heart attack, especially if that is confirmed on the EKG, and we look at the ST segment for that, the ST segment. So it's troponin plus ST segment changes, usually elevation of the ST segment, but that tells us the patient is having a heart attack. The axis normally leads 1 and AVF should be upright. The QRSs should be pointing upward. If they're not, then something has caused the axis to change. That could be enlargement of the left ventricle, it could be enlargement of the right ventricle, something that shifts the electrical activity of the heart. If a portion of the heart muscle has died, that will also shift it. So there are lots of factors involved in this, but the cardiac axis is important and it's determined by leads 1 and AVF, both of which should be upright. If they're not, we have an axis problem and we need to figure out, why that is taking place. All right. Hexaxial reference system is the actual finding the degrees of axis. Respiratory therapists don't do this, so I'm not going to spend a lot of time on it. But you can actually calculate the degrees of axis in the heart. Exactly where is the axis? And honestly, we just don't do this. It's not part of respiratory therapy. The cardiologist, I think, sometimes does, but it tells us exactly where the axis is pointing. As you notice, there's a normal range, and it's a pretty good sized range, but outside that range, something has caused the axis to shift. All right, lead 1, lead 2, lead 3. This is the normal pattern that you should be seeing, the way that they appear. Notice that lead 3 is partly upward and partly downward. That's normal in lead 3. If you see that in lead 1, something's wrong. The lead that we look at most often when we're doing rhythm strips is lead 2. Lead 2 gives us the best overall look at the heart, and that's why we, most often look at lead 2. Right axis deviation, you will see lead 1 upright, lead 1 downward, negative deflection. So that's a right axis deviation. If you see a left axis deviation, which I'm going to guess is the very next slide, there's your right axis deviation where lead 1 is downward. A left axis deviation, it is AVF. That is downward, negative deflection in lead AVF. Now, I got to be honest with you, most respiratory therapists do not deal with the heart axis on a day-to-day basis. But what you'll see is that leads that should be upright are now downward. And there's a reason for that. Maybe a previous heart attack, maybe enlargement of the left ventricle or the right ventricle. And that's about all you need to know about that. So now we go to normal sinus rhythm, which is the rhythm that probably all you folks are in right now. It's the rhythm that I'm in. I actually hooked myself up in class the other day to show students my heart rhythm, and it's just normal sinus rhythm. Good, right? PQRST. So what normal sinus is PQRST and a rate between 60 and 100. You're going to learn here in a minute that slow rhythms are called Brady and fast rhythms are called tachy. You may have learned that somewhere along the line already. But PQRST with a rate of 60 to 100 is normal sinus rhythm. Now, arrhythmias can be either supraventricular or they can be sinus. If they originate in the atria but not in the sinus node, that's called supraventricular. If they're in the sinus node but slow, it's called sinus bradycardia, heart rate less than 60. And that's a number that you definitely need to memorize. Heart rate slower than 60 is bradycardia. Also, a heart rate faster than 100 is tachycardia. And that may be the very next thing. Yep, sure enough, sinus tachycardia is a heart rate greater than 100. So nature is happy. I know I talk about nature a lot. Students, comment on that, but it's just true. Nature's in charge. We just do what we can to support nature. But nature wants your heart to beat between 60 and 100 times per minute. In that range, the heart does well. If it gets out of that range, then bad things start to happen. Supraventricular tachycardia can go as fast as 150 to 200 per minute, even 250. And what that means is the heart does not have enough time to fill with blood before the next beat happens. So that's not good at all. That is way too fast. And the heart is not efficient when it's beating at 150 to 250 times a minute. Way too fast. Yeah. Sometimes the SA node varies from beat to beat, and that's called sinus arrhythmia. If there's more than a 10% variation, that's called sinus arrhythmia. We really don't worry about that rhythm too much. It doesn't usually lead to bad things. But here's something that can really lead to a bad thing. When the SA node fails to fire, it just kind of takes a few beats off. you know, I'm just going to take the next few beats off. Hope you'll be okay. Well, that's not good at all because then the heart rate is slowed down to zero during that time. Not good. The sinus arrest will lead to an investigation to find out why, and it may lead to the patient having a pacemaker. If the SA node is not going to be consistently reliable, patient's probably going to get a pacemaker. Atrial premature complexes, which most of the world calls PACs. Uh, I'll just change that to show what you'll see at the hospital. You all have a few of these. This is where a place in the atria, not the SA node, but a place in the atria, takes over and gives an early beat. That early beat looks a heck of a lot like a normal beat, but it just comes early. We all have a few of these. We're really not too concerned about these unless there are a lot of them. And a lot of them would mean, several per minute. Every other beat is a PAC. That's called atrial bigeminy. We don't see that very often. But we are interested and concerned if it becomes atrial flutter. That's where the atria are actually fluttering instead of having individual separate beats. And also, the atria can fibrillate, where the atria are just quivering. They're just quivering and they're not actually pumping blood. I can't tell you how many patients we have in atrial fibrillation. Oh my gosh. You'll see this when you get to the hospital. So many of our patients are in atrial fibrillation. And the problem with that is that once in a while, the ventricles try to keep up with the atria and they can't. If they try to, the patient's going to be in real trouble because that's too fast to pump blood. That is called atrial fibrillation with RVR. Let me just mention that, which is rapid ventricular response. And there we go. Atrial fibrillation with RVR. Junctional rhythms, if the SA node is not doing its job, the AV node will take over as the pacemaker, but it takes over at a slower rate, usually about 40 to 60. Here's the key thing: you won't see a P wave. If it's a junctional rhythm, meaning it's coming from the AV node, let me actually just add that right there. Junctional rhythm coming from AV node, then there will not be a P wave. Let's see, acute coronary syndrome. This is where the heart muscle is not getting enough blood supply. And ST elevation MI is the classic example of that. There are some heart attacks that are called non-ST elevation MIs. Those are a little more sneaky, and we have to rely on other things like troponin. There's troponin to confirm those. But I would say the large percentage of heart attacks do have an ST elevation, which helps us to identify them. Yeah. We'll show you some examples of that as we move ahead in the course. Ventricular arrhythmias are generally considered more serious. Now, all of us have a few premature ventricular beats. That's where a spot on the ventricle gets irritable and does not wait for the signal to come down through the usual pathway. So when that happens, we get an extra early beat that comes from the ventricle. These beats are wide and bizarre looking. Wide and bizarre looking, okay? They don't look like a normal beat at all, and they always come early. If you get a long run of those PVCs in a row, that's called ventricular tachycardia. That one is dangerous. What can happen there is that the patient may not have a pulse. Ventricular tachycardia without a pulse and ventricular fibrillation are the two shockable rhythms. Two shockable rhythms, these are the ones that get defibrillated, are ventricular tachycardia without a pulse and ventricular fibrillation. Those are your two shockable rhythms that get immediately defibrillated, and you definitely need to know that for boards and probably for this test also. All right, ventricular flutter is really just a kind of V-tach where the heart goes very fast, 250 to 300 times a minute. That's a more serious type of V-tach, and it is less likely to have a pulse. That's the important part. Yeah. Looks like about 12 slides left here, so we'll finish this one in pretty good time. So now, if there is no more contraction at all, if the heart is completely idle, silent, that's called a systole. And we happen to know there's a board question where you are asked, do you defibrillate a systole? Well, here's the funny thing. On TV, if you watch a medical TV show, they do. The flat line is on the monitor. Somebody grabs the paddles and shocks the patient. But in the real world, asystole is not a shockable rhythm. So it's only VFib and VTAC without a pulse that get defibrillated. Terry, you home? Welcome. Torsades de poids. This is a specific kind of cardiac rhythm that is very serious. It's a type of ventricular tachycardia. Guess we'll have to show you a picture of that later. I was hoping they would have a picture, but it's where there is a crescendo decrescendo pattern. I love that description, crescendo decrescendo pattern. And it builds and it falls. It builds and it falls. That is torsades. The most dangerous cardiac rhythm is ventricular fibrillation, VFib. This will kill you in about 5 minutes. That's all it takes because there is no blood flow. There's also a rhythm called pulseless electrical activity, PEA. That one's kind of spooky because you see a rhythm on the monitor, but you don't feel any blood being pumped. There's no pulse, there's no blood pressure. So something else is causing that to happen because the rhythm looks pretty good on the monitor. but there's no blood flow. So we must find the reason that that's happening. All right. Now we give you some examples of genetic heart problems. Brugada syndrome is one of those. It is a genetic disorder and can actually happen at any age because of the genetic nature to it. Um, but you see something called a J wave, which most of us do not have, also known as the Osborn wave, J wave, Osborn wave. And that tells us that patient has a congenital genetic heart problem called Brugada. Let's see if there'd be a picture of it. There it is. Yeah. It's like a second R wave that happens right after the first R wave. And that can indicate a very serious cardiac problem. Nothing the patient can do about that. We can help. We can do a pacemaker. We can do other things to help. But there you go. AV blocks. This is probably one of the more complicated things for for students to understand. Sometimes I'll call you guys patients, and sometimes I call my patients students, get confused. First degree AV block, that's where the PR interval is longer than zero point 0.2 seconds. By itself, the patient may not even feel this happening, so it's not that serious to the patient, but it has been known to progress to second and third degree. Second degree, type 1, is progressive lengthening of the PR interval and then an occasional total dropped beat. There just is no beat. The patient definitely feels that. And if it happens several times in a row, they may be dizzy or they may even pass out. Second degree type 2 is where you have some P waves that do not lead to QRSs. And that has been known to progress to a complete heart block. So, third degree block, there is absolutely no correlation between the P waves and the QRSs. Consequently, this is a life-threatening situation. This always results in a pacemaker. Third degree AV block. And that's a question they might ask on boards is, what do you do for a third degree block? There's no other solution that will save the patient's life. They must have a pacemaker. Okay, so there are all these different problems that can happen in the heart. It all starts with PQRST. PQRST. Then the contraction is considered a sinus rhythm. Now, there may be a delay in the bundle branches that gives us a rabbit ear or letter M type appearance. I call it Bugs Bunny. BB for bundle branch, BB for Bugs Bunny, rabbit ears on the cardiac rhythm. So they do kind of look like an M or a W if the patient has a bundle branch block. And we can tell by which leads that's in as to, is that a right or a left bundle branch block? So here are 3 simple steps to help you with this as you're learning it. I'm actually going to send you a full set of cardiac rhythms that I have collected over the years, and they're great ones. They're, really clear, easy to make sense of. I'm going to send those to you. Is the heart rate rapid, slow, or normal? Is it a rhythm that is normal, or is it inconsistent? And then evaluate the pattern of P, QRS, and T. Are they always connected? If they are, it's a sinus rhythm. If they're not, it's some kind of heart block. All right, so to summarize, the heart, very important pump that moves blood through your body. Obviously, we've got to have oxygen in, carbon dioxide out. Without the heart, we would never get the blood to the lungs for that to happen. Normal sinus rhythm is PQRST, as we have now shown you. And then think of all the different variations of that. Arrhythmias are just any time that the heart is not functioning in a completely normal way. Supraventricular arrhythmias happen above the ventricles, meaning somewhere in the atria, but not in the SA node. And ventricular arrhythmias come from the ventricles themselves. Generally, we think of those as more serious arrhythmias like VTAC without a pulse and VFib. The blocks, first degree, second degree type 1, second degree type 2. I'm going to send you examples of all of these, and third degree AV block. There you go, and we did it in 35 minutes. So there's your introduction to EKGs. And I will now send you the heart rhythms and also post this recording in the course.